Cardiology 2. We are going to talk about acute coronary syndromes and myocardial infarction. Acute coronary syndromes, according to the current definitions, are three entities which are only vaguely separated from each other. There is unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. Okay? Each of these represents a progression of a continuum. So let's talk about how you develop a heart attack, because it is also how you develop each of these processes. All right? All of us in this room have what we refer to as fatty streaks in our vessels. Okay? Nobody who eats a North American diet doesn't develop these. Okay? So, fat is not supposed to be in arteries. It gets deposited there as a combination of environmental and genetic factors. The body knows that this fat is not supposed to be there, and it deploys the immune system to try and clean it up the same way that it would a foreign invader, okay? So we send out these macrophages to these lipids, and the macrophages say, I better clean that up. But here's the thing, macrophages only have a couple of tricks in their arsenal. So first the macrophages go up to the fat and they go, oxidize, and it doesn't work. And they go, oxidize, and it doesn't work. And they go, oxidize, and it still doesn't work, okay? So then they get really pissed off, and then they go Hulk, okay? And they turn into what we call foam cells. Now, these are macrophages that are way pissed off, okay? They got like 40 nuclei in them, and like if you ever see one under a microscope, I mean, it's a scary looking cell. These things are behemoths, okay? I mean, they can secrete pure hydrogen peroxide inside them, and they take this stuff and they do oxidize that fat. But here's the thing, you didn't want the fat oxidized, you just wanted it gone. So what they do is they create foamy lipid. They stir this stuff up and they create this concoction, and that concoction is not terribly different from soap, and it's not any better, but now you have a massive immune reaction going on in your arteries, okay? And this immune reaction then leads to chronic inflammation. It leads to all of the things that chronic inflammation usually leads to. Now, the end product of all inflammation is fibrosis and calcification, okay? So what happens is you build up this inflammation, some of that turns into calcification, which is where you get those hard streaks in the arteries that you can see on x-rays and CT scans. That's limestone, guys. That is actual rock deposition in the artery from that calcification, from this chronic, all the time, all day, every day inflammation in these arteries as a result of this reaction. Now, ultimately what happens with the arteries is that they reach a state where someday, for some reason, they pop like a zit, okay? So you gotta think of this like a 13-year-old with the world's worst case of acne. He's walking around with a face full of zits. Is it gonna be that one? Is it gonna be that one? Is it gonna be that one? I don't know, but one of them's gonna pop, right? Same thing happens with a heart artery. You have this big angry reaction happening. You've got these nasty foam cells firing away, big inflammatory reaction, and one day, the artery wall can't take it anymore, and it ruptures. So what happens? The bloodstream gets exposed to all of this nasty garbage that we just talked about, and the body freaks out. It's never seen these chemicals before. There's huge amounts of inflammatory chemicals being secreted at the local site, and you just blasted a shotgun hole through the wall of one of the body's most important blood vessels. This cannot be good. So what does the body do? It goes, yeah. And I told you before, the body is stupid. Okay? The body does not have a different reaction for a coronary artery than it has for any other artery anywhere else in your body, okay? So it's gonna do the same damn thing in the coronary artery that it's gonna do in any other artery. It says, well, if there's a breach in the vessel wall, and I guess we should put a clot on it. Great idea if you nick yourself while shaving. Terrible idea if it happens in a coronary artery. The reaction the body should have is nothing at all. Leave it alone and let the vessel heal over. But it doesn't do that. It does the same thing that it would do if you nicked yourself shaving. So platelets come along, they attach themselves to the vessel wall. Platelets are always the first line defenders in a trauma, okay? Platelets show up in what we call the rolling phase. Then they stick to each other in what we call the adhesive phase. And then they cross-link factor 13, you know, all those clotting chemicals, they cross-link factor 13 to create fibrin, which is like the rebar in concrete, okay? It locks it all down into a big solid clot. And then finally, that fibrin does something called cross-linking, and that's where the clot goes from being something you can wipe off with your finger to being something hard that you have to pick off, because that fibrin is cross-linked, okay? So what unstable angina, NSTEMI, and STEMI represent is varying progressions of the process that I've just described to you. In unstable angina, the plaque has ruptured, but a clot has not yet formed on that vessel, or it is forming intermittently and being washed away by the bloodstream almost as soon as the clot forms. With me so far? In an NSTEMI, the clot has formed, but it is incomplete. It has not completely occluded the vessel. So there's still some blood flow getting through, but there's not enough blood flow getting through. And in a STEMI, the blood vessel has completely occluded. From top to bottom, the blood vessel is closed for business. If there's any flow at all, it's only the tiniest little trickle, okay? But it's all the same process, okay? Now, what causes this? Type 2 diabetes, hypertension, abnormal blood lipid levels, tobacco, physical inactivity, obesity, they all contribute, but they are not causes, they are contributors. There are people who will live their entire lives with the worst habits you've ever seen and never develop coronary disease. Genetics play a huge, huge role here, okay? How do you figure out whether someone has a heart attack? What they're trying to tell you is to ask the OPQRSTs. Have you guys heard of this? Yes. Onset, precipitating factors, quality, radiation, severity, and timing. So the typical description of angina of any form, whether it be from an acute myocardial infarction, unstable angina, or chronic stable angina, is the following. I have a substernal chest pain, which is constricting or vice-like, with radiation to the shoulder, neck, or jaw, with radiation down an ulnar distribution of the arm. However, there are lots and lots of things that can also occur. And the reason for this is that the heart does not have its own somatic, we call it nervous system. It does not have a spot on the brain. Do you guys know what the homunculus is? That weird little thing in the brain that shows which neurons go where when you're feeling something. There is no homuncular spot for heart. So what happens is when something's wrong with your heart, it just hijacks whatever nerves happen to be in the area and creates weird symptoms based on that, okay? So you can have shortness of breath, for women in particular, fatigue. You can have sensations like you have heartburn, like it's burning down low in your chest, kind of right at the diaphragm level. I'm not sure what this is all about. Apparently you can develop 2 new girlfriends you didn't know you had. Yeah, so anyway, what they're trying to get at here is be cautious of these things in the elderly and in women. In the elderly, because their nervous system is not as good at reporting those somatic sensations. Just like peripheral sensation is decreased, the receptive sensations of myocardial infarction can be greatly decreased. They may tell you that they had nothing more than fatigue, or they felt a little weird, or they were dizzy earlier that day. You check a trope, it's like 23. All right. In women, they more often than men present with atypical symptoms. People have made a huge deal out of this out of the year. It turns out if you actually just talk to your patient and listen to what they have to say and order a troponin if you have even mild suspicion for a heart attack, you're going to catch most of this, okay? Now, in physical examination, what they're trying to tell you is figure out what this person looks like. Are they a raging lunatic having a huge anger issue or some sort of emotional disturbance? Are they profoundly fat? Do they have massive jugular venous distension indicating right heart failure, left heart failure, or right heart failure secondary to left heart failure? Do they have a sternotomy indicating that someone has already bypassed them for coronary artery disease, right? And then they said check for cardiogenic shock with low blood pressure. Okay, now here's the key. These numbers aren't actually even right. It's much, much higher, actually, but this should be 13 or so. The point is, while I gave you the classic textbook description of chest pain, radiation to a different arm doesn't make it better, Okay, like I said, the heart's sitting in the middle of the chest and it just grabs a hold of whatever sensations it can get from the nearby area. It may radiate to the right shoulder, it may radiate to both shoulders, and it may or may not be associated with what we call diaphoresis. It all depends on whether the patient gets a big adrenaline surge from their heart attack. If they do, they will have diaphoresis. If they don't, they won't. Okay, so you can only sort of rely on that. However, there are things that can tell you it's probably not, or at least that it is less likely to be, a heart attack. If someone says, oh, I have really bad chest pain and it hurts every time I take a deep breath, that's pericarditis, friend. So unless the pericarditis came from the heart attack, you may be barking up the wrong tree. Positional chest pain, if they say, oh, it's way worse when I lay down and way better when I sit up, again, they're describing pericarditis, okay? It hurts more when you lay down because the heart is rubbing itself when you lay down. When you sit up, the heart's dangling freely, so it doesn't have to rub up and down against that irritated pericardium. If they say that it's sharp, okay, like it's like I'm stabbing with a knife, that's what they mean by sharp, not just like, oh yeah, it's like really intense. That's why you gotta be clear with these guys. What do you mean when you say sharp? Do you mean like someone stabbing you with an ice pick, or do you mean like it was really, really bad? Stabbing with an ice pick, rarely a heart attack. Reproducible, what they mean by that is if you just take your hand, you just mash on their chest, and they go, ah! Okay, that's your chest pain. And then you look at them and you go, is that about the same as your chest pain, only worse? Yeah, I mean, that was much worse. Perfect, we're good here. Okay, you have costochondritis, let's move on, right? Now throw one other thing out there. If the pain only lasts seconds, okay, it is not cardiac. As soon as a patient's in the office and they tell me, oh yeah, I have these chest pains every once in a while, how long does it last? Because you know it's not gonna be anything. How long does it last? Well, I mean, sometimes as much as 3 to 5 seconds. Done, okay? Angina is a process of occluded blood flow, all right? If you put your heads down, because my lecture is boring, and you lay on your arm for 5 seconds, is your arm gonna fall asleep? No, of course not, don't be silly. The same thing is true of the heart. If you occlude the blood flow to the heart for 5 seconds, you're not gonna get into these sorts of situations. These are things that develop gradually over minutes and relieve over minutes. It can last anything from minutes to hours, okay? It cannot last more than hours. If they've had chest pain for 5 days, it is not cardiac. It cannot be if it's continuous pain for 5 days. The muscle would have died by then, okay? Remember, it hurts because it's dying. It's either going to die or it's going to get its blood flow back, but one way or the other, 12 to 14 hours later, the problem should be over, okay? Okay, this is exactly what I just described to you as to the development of these plaques. So you have the asymptomatic fatty streak, you have a stable fixed streak with those angry cells firing away in there, and then you rupture that plaque, you start to form this reaction, this platelet clotting reaction. If you partially occlude the vessel with a thrombus, that's non-ST elevation, and once you've fully occluded the vessel, you must open it right then. There is no residual blood flow supplying the heart. Okay? Okay, very good. There are a couple of types of MI. Type 1 is what I described to you. It's this thing where the plaque ruptures. It's the thing we activate the cath lab for. Type 2 myocardial infarction is very important to recognize. That's where the patient doesn't have the greatest blood vessels, but their real problem is some other medical illness, okay? You get some 80-year-old guy with a 20-pack-year history of smoking, and this guy's got the flu, and he gets a trope of 3. And it doesn't really go up and it doesn't really go down. That guy has a type 2 MI. That just means his heart's working harder than it usually does because he's busy dealing with this fever of 105 while he's got the flu, and his heart just can't keep up. It's overworking itself, okay? Think of it like going to the gym, okay? You lift 200 pounds every day, suddenly you decide to go for a PR. You lift 250, right? Oh my God, your arms are shredded, right? It hurts. Physically hurts, not just then, but on an ongoing basis. Same idea. You have damaged your muscle and not in a good way. Same idea here, okay? We've worked the heart harder than the heart is capable of working. That's a type 2 MI. All right, these are the various forms of ST changes that you can see on an EKG. They generally progress in this order. So you start out with a normal QRS. There is no Q wave at the start of the QRS. Please note that. Then the patient becomes ischemic. the T wave inverts. Then the vessel completely occludes and you start to get ST elevation. And then that infarction completes. The tissue now has no blood flow remaining. It's used up its entire supply. Front to back, the heart has no blood. And now you get the full ST elevation effect. Then that tissue dies and the ST elevation goes down. Q waves started developing back here, continue to develop. And you get some residual T wave inversion from what we call the border zone. Okay? That's tissue that's still ischemic upstream, but not so bad off that it's dead. And then ultimately, you end up with your healed infarction where you have a big Q wave left over as a marker of that infarction. All right? Okay. Very good. So, when you are analyzing an EKG for myocardial infarction, you need to analyze it by territory. The EKG looks the way that it looks because it's more than 100 years old. Okay? They invented the portions of the EKG in order. First, they invented 1, 2, and 3. Then they invented AVR, AVL, and AVF. Then they invented the precordial leads. Okay? However, this is not the correct way to order an EKG for it to make sense. And people have tried to redo this, but it's just like the QWERTY keyboard. Why the hell should a keyboard be QWERTY? Makes no sense at all. Who knows how to look for letters like that? Same idea, okay? It's historical artifact. And the story about trying to slow down typists, by the way, isn't true. Don't repeat that at a bar. You're going to lose some money. So you got a couple of territories worth knowing. You've got the inferior territory. That's 2, 3, AVF, okay? You've got the lateral territory. That's V5, V6. You've got the high lateral territory. That's 1 and AVL. You have the septal territory. That's the septum in between the left and right ventricles. That's V1 and V2. And you have the anterior territory, V3 and V4. So each of these corresponds to 1 or 2 arteries that are most likely to supply that area. So when you see changes in these regions, a trained cardiologist will know what vessel is most likely to have caused that infarction. There are a lot of places you can find something just like this. There are little cards that have it. You can do a Google image search on EKG territories and find these clustered. There are a lot of ways to get this information. But when you look at an EKG, the first thing you have to train a new reader in is to recognize the zones. You have to know the inferior zone, the high lateral zone, septal zone, anterior zone, and lateral zone. Okay, so what is a STEMI? A STEMI is an elevation of the ST segment of at least 1 millimeter, and here is the key, in at least 2 contiguous leads. Contiguous means 2 leads in the same territory, okay? 2 leads in the same territory. The exception to that is V2 to V3. The reason for that is because lots of people have a little bit of ST elevation in V2 and V3 all the time. It's called early repolarization. You don't have to worry about that. Okay? There you need 2 millimeters of elevation and preferably 2.5. Okay? If the patient has a new left bundle branch block and you are not a cardiologist, you won't be able to read whether or not they have ST elevation or not because left bundle branch block screws things up. It turns out there's actually a way to read through the left bundle branch block called the Zgarbosa criteria for anybody who wants to know. It's SGARBOSSA. All right, so all this is saying in all of these different things is that you have elevation in the appropriate territory, okay? So a STEMI in some territory means you have an infarction in that territory, okay? There are a couple of notable exceptions. If you have left main disease, you're probably going to have ST depression everywhere, and AVR is going to have ST elevation, real ST elevation, okay? That's a very, very high-risk finding. Posterior MI, none of the leads on a standard EKG look at the back of the heart. They're all designed to look at the front and the side, okay? They do not look at the back of the heart. So to figure that out, what you have to figure out is that they have an inferior MI, and then you've got to realize that there's too much R wave and too much ST depression in V2, okay? All right, very good. So, right here, they're showing you some EKGs. This should be fairly obvious. With most heart attacks, the ST depression should have reciprocal ST depression. This is another key differentiator between a heart attack and pericarditis. Pericarditis does not have reciprocal ST depression. Only heart attacks do. What you're seeing is the change on one side being reflected in the opposite change on the other side, okay? So here in the septal territory, V1 and V2, we see this massive ST elevation. Goes on to V3, now we're in the anterior territory, right? V4, still anterior territory, still got a couple of millimeters of ST elevation. It's gone by V5 and V6 because that's the lateral territory, right? The opposite of anterior is inferior in the heart, right? So it's no surprise that when we look at the inferior leads, we have this ST depression in the inferior leads. So we would call this an anteroseptal myocardial infarction. Anytime you have more than one territory, it should never be more than two territories. You just name the territories that go together. So if it was V3, V4, V5, and V6 that had the ST elevation, what would the name be? Anterolateral MI. There you go. You got it. If it's 2, 3, and AVF and V5 and V6, what's the name of that heart attack? Inferolateral. You got it. See, it's just that easy. You guys are already pros. All right. So here is another EKG. This is designed to show you a left main heart attack. Note that there is ST depression everywhere. Inferior territory, check. High lateral, check. Lateral, check. Anterior, check. Everything has ischemic changes. And here's the key, when you go to look at AVR in this one, all the way up. Call the cath lab. You got a problem. Okay? Okay. Who needs acute PCI? The answer is somebody with a STEMI and somebody you can't get chest pain free by any other means. That's the answer. Okay? However, these things are all various people who may need to go to the cath lab. All right? Okay. Acute coronary syndrome used to be that the treatment for this was Manhabit, morphine, aspirin, nitro, heparin, oxygen, beta blockers, and either intervention or thrombolytics. Manhabit. All right, fantastic. Like almost everything in medicine, the more we study it, the more we realize that the stuff that the 80-year-old guys told us was mostly stuff that they just tried and it didn't really work out once you study it rigorously. Oxygen, minimal benefit, if any. Morphine mostly makes the patient feel better. Yes, it has some effects on myocardial blood flow alteration, but mostly it just makes it so that the pain is less. Heparin, not as important as it originally seemed, but still useful. Beta blockers, again, useful. You need to give someone oral beta blockers as long as they have a systolic blood pressure greater than 100 and a heart rate greater than 60. And intervention or thrombolytics are still the mainstay of treatment for acute ST elevation myocardial infarction and chest pain that you can't get rid of any other way, as long as you feel pretty sure it's a heart attack. Okay? An aortic aneurysm is a dilation of that aorta. Remember I talked to you earlier about the aorta as the charge vessel of the body. You charge it up like charging a crossbow. That's actually what it's called when you cock a crossbow. Charging the crossbow. Okay? But it turns out, in order to do that, you got to have bungee cords in the wall of the aorta, right? You got to have something that can stretch way out and then come way back. And it turns out that's actually harder than you'd think. The way that that's done is a balance of fibers called fibrin and elastin in the body, and this elastin molecule is not properly made in certain patients, okay? People with Marfan syndrome, people with connective tissue disease, people with Ehlers-Danlos syndrome, do not manufacture those elastic proteins well. The heart beats 30 million times a year, and that's the number of times the aorta has to expand and contract, okay? If you have a genetic predisposition, your aorta is not well built, then over time you will rupture more and more of those fibers the same way you will rupture more and more of the fibers in a rubber band as you continue to stretch it out, okay? Most people can make it through their entire life without this happening. Some people cannot. An aortic aneurysm is a big deal. What is the cardinal sign of an aortic aneurysm? It's going to be chest pain, okay? These are going to be people who have pain, and then everything else that they have about it comes from the mass effect of the aorta, okay? So this thing can bulge out. Anything over 5 to 5.5 centimeters is at risk for rupture and probably needs to be considered for repair, all right? The people who are most prone to get this are people with bicuspid aortic valves in the chest and people who are smokers for the abdominal aorta, okay? All the other signs and symptoms of abdominal or thoracic aortic aneurysm come from that large dilation pressing on things. So up here you've got the recurrent laryngeal nerve that makes you hoarse. You have the throat, so you can get airway constriction or difficulties taking breaths. You can get wheezing. In the abdomen, you can get belly pain. You can get mesenteric insufficiency. You can get renal dysfunction if it's so large and it's near the kidney arteries. All of these things can occur. These are just some nice pictures of aneurysms. This is the more normal segment. This is the aneurysmal segment bowing way out here. So the problem with this is that there is something called the law of Laplace. And the law of Laplace says that if you put any vessel under a fixed amount of pressure, the larger the vessel radius, the higher the tension on that wall, okay? All materials will rupture at a constant tension, okay? So it's the same thing with your dive tanks for those of you who are divers, okay? All materials will rupture at a constant tension. That's why there's a maximum fill pressure on your dive tank. If you want to go for more oxygen in the same size tank, you've got to change the material that the tank is made out of, or you have to get a bigger tank, okay? The only other option is to change the thickness of the wall of the tank, all right? In the human body, you can't change the thickness of the wall. In fact, ironically, it gets thinner and thinner as the thing keeps dilating out, right? Okay. Alrighty, now, an aortic aneurysm can then result in an aortic dissection. This can occur without an aortic aneurysm, but it usually comes from an aortic aneurysm first, okay? We talked about that wall of Laplace. We talked about rupture of fibers under tension. What can happen is that under enough tension, you can rip a tear in the aorta. Remember, this is a pressure vessel, okay? It's under extremely high pressure, charged by the heart. That pressure is sufficient once you tear the inner lining of the aorta that the pressure can finish the job from there, okay? So it's, I don't know if you guys have ever done this, it's tons of fun if you haven't. If you grab a really good knife and you just start at the top of a big piece of cloth, and you just stab the piece of cloth, you can just ride that knife all the way down, okay? It'll break you all the way down, but you will finish rupturing that piece of cloth. It's tons of fun. You can get like 100 runs out of a single sheet. It's fantastic. So anyway, same idea here. Once you make that tear, that thing is going to keep going, okay? And it will finish the job all on its own if you don't intervene. So an aortic dissection is a crisis. It requires immediate and prompt intervention if it occurs in the chest. If it occurs below the arch of the aorta, many times medical management is more appropriate. But in the chest, you got a big problem. Because what's going to happen is that thing's going to tear back into the aortic valve and it's going to rip the attachment of the heart to the aortic valve, or it's going to rip those vessels. And what is it that comes off these first two branches of the aorta? You got it. You're going to stroke. Got a big, big problem on your hands. Make the call immediately. What's the cardinal sign of aortic dissection? Yes, back pain, back pain, back pain, okay? If someone describes it as a tearing back pain, like some giant invisible being is literally tearing them apart like a piece of paper, they have a dissection until proven otherwise. They have a dissection until proven otherwise. They have a dissection until proven otherwise. If they are calmly telling you that they have this pain, they probably don't have this pain. Aortic dissection pain is usually incredibly intense. The patients are in agony. It hurts tremendously in the majority of cases, okay? There are exceptions to every rule, but that's usually how it's going to go, all right? So what you will notice if the dissection occurs between this vessel and this vessel, which is a very specific finding, is that you'll have a difference in blood pressure between the arms, okay? The only two things that on a test are going to give you differences in blood pressure are an aortic dissection and what's called a coarctation of the aorta, which is a pinching of the aorta right before that third branch right there, okay? Those are the only two things that are usually going to cause that. Okay? New murmur. If you have a new murmur, you are in all the trouble. because that means the dissection has already made it all the way back to the aortic valve, and it's tearing the aortic valve apart. It's opening up real wide. Neurologic deficit, again, you lost the game already. They've stroked. They've dissected off one of their carotids, and they've had a stroke. That's where the neurologic deficit comes from. Syncope, I guess. Again, if you have syncope from this, that means you've dissected into your carotid baroreceptors. You are in all the trouble. Okay? All right. Aortic injury is just an aortic dissection that has become too massive for the vessel to maintain any integrity. So an aortic dissection is a tear. There are 3 layers to the aorta. Okay? Intima, media, adventitia, 3 layers. An aortic dissection is a rupture between layer 1 and 2 or layer 1 and 2 and 3. Okay? Once you tear layer 3, it's game over. They're dead. They'll be dead in seconds. There's nothing you can do about it. It's over. Okay? It's a high pressure vessel. There's no way you're going to get them on bypass in time to fix this before they bleed out in the next 20 seconds. All right? So, this is what we're talking about here. You've got grade 1, that's an intimal tear. Grade 2, intramural hematoma. That means not only have you torn a hole in it, but it's now filling up with blood under pressure. This begins the process of a dissection. Pseudoaneurysm. This is very, very bad. This means layers 1 and 2 are completely ruptured and only layer 3 is still hanging on. And then layer 4, or grade 4, layer 3 has ruptured and the blood is now freely extravasating into your chest cavity. You'll be dead within seconds. Give them all the morphine. Just make their last few seconds on Earth reasonable, okay? Because they're gone. Pneumothorax. Pneumothorax comes in 2 flavors, open and closed, and then a closed pneumothorax comes in 2 flavors, tension and non-tension, okay? An open pneumothorax is what we want. If we have to have a pneumothorax, that's one that can equilibrate with the outside air. That's what you do when you create a chest tube, is at first you create an open pneumothorax where you previously had a closed pneumothorax. So most lung trauma is one-way trauma, okay? Air can get out as you inflate the lungs under pressure, but air does not go back in because there's no incentive for it to do that, right? The lungs are never under negative pressure. They're just under less positive pressure. Does that make sense? So there's no reason why air would ever go back into the lungs. So if the air can't escape the chest wall, then all it can do is accumulate. Okay? Now, you hope that you don't accumulate enough air to completely collapse a lung, but once you have accumulated enough air in a closed pneumothorax to completely collapse a lung, you then progress to a tension pneumothorax. You are still pumping air into that chest cavity, but you have collapsed all the lung tissue you can collapse. There's nowhere else for there to collapse in that lung, but the mediastinum seals it off. So what happens? It starts pushing, because that air keeps going, man. It's a fluid. It's a compressible fluid, but it's a fluid, okay? So it just pushes more and more and more, and it squeezes everything else in the chest, and it will push all the other structures off to the other side. How do you know a patient has a tension pneumothorax? Can't breathe, and? Huh? One, and what's the cardinal sign? Absent breath sounds on the affected lung, okay? They always say, if you've made the diagnosis of a pneumothorax on a chest x-ray, you have screwed up, okay? By the time the chest x-ray is there, you should have already had an 18-gauge angiocath in the second intercostal space anteriorly in the mid-clavicular line. Let me say that again. An 18-gauge angiocath in the second intercostal space in the mid-clavicular line. They've actually tested this. That is the optimal location, catheter size, and position to reinflate a lung with a minimal risk of severely disrupting a patient. They've also shown that for at least 1 hour, that 18-gauge angiocath will be as effective as a chest tube at keeping the lung reinflated. 18-gauge angiocath will eventually clot off, but you will save a life with that, okay? Every battlefield kit you will ever see will have a specially made tool, which is an 18-gauge plastic retainer angiocath designed to be stabbed directly through the chest wall, okay? You leave behind the plastic tubing. You convert the closed pneumothorax to an open pneumothorax until you can place a chest tube, all right? Esophageal rupture, this is almost always due to vomiting. okay? This is called a Boerhaave syndrome, when you vomit so hard that you rip your own esophagus. Please do not do that. If you have, you've been drinking too much the night before, or you are in a hostile country with a terrible water supply. Drinking straws, life straws, gentlemen, please. Do not get this kind of nausea and vomiting. How do you know that they have this? Well, a couple of signs. They have subcutaneous emphysema, which is what they're trying to show you in this very poorly contrasted x-ray here. So you have air in the skin tissues themselves. How did you get that? You ruptured the esophagus is filled with air. We all swallow air all day long, and that then extravasates into the surrounding tissues. The patient will have vomiting. They will generally have hemoptysis. They will generally be complaining of coughing up blood. Okay? All right. Tamponade, we've already talked about. Do you guys feel like we need to hit tamponade again? What's the cardinal sign of tamponade? Huh? Muffled heart sounds in the setting of shock. You got it. Beck's triad, JVD hypotension, muffled heart sounds. Again, muffled heart sounds, muffled heart sounds, muffled heart sounds. Okay. Pericarditis, we've already covered it. What's the number one cause? Viral illness. What's the number two cause? Acute myocardial infarction can cause pericarditis. What's the number three cause? Tuberculosis. What's the number four cause? Cancer. Well, actually, they've reversed now, so cancer's over tuberculosis anymore, but same idea. Okay. Endocarditis is an infection of the heart. This has absolutely nothing to do with emergency medicine. At no point in time will you be doing an ambulance diagnosis of endocarditis. But the number one cause of endocarditis is intravenous drug use, thank you. And what it is bacteria growing on valves, vegetations, pacemaker leads, or artificial heart valves. God help you if it grows on an artificial heart valve or a pacemaker lead, because you cannot sterilize them in the majority of cases. If it grows on an artificial heart valve, the bacteria will literally chew the sutures that they use to secure the valve out of the way. The valve will start flapping around. It's called a paravalvular leak. So Janeway's lesions are flat, painless spots on your fingers and toes. The key here is the word painless, okay? So if you need to remember this, Mary Jane will never hurt you, okay? Osler, he was a famous physician, really nice guy, incredibly observant. He found the painful ones, okay? So these are the same idea. You have these sort of nodules on the fingers and toes, but they really hurt. Okay, so if it hurts, it's the guy. If it doesn't hurt, it's the gal. And either way, they should be on your feet and your hands. Okay, Osler's nodes are much more specific for endocarditis. I have diagnosed dozens and dozens of cases of endocarditis. I got to be honest with you, I've never seen Janeway's lesions or Osler's nodes. I've seen every other sign and symptom of endocarditis. Never seen either of these two. GERD, peptic ulcer disease, that just causes heartburn, okay? We all know what heartburn is. The problem is it's a diagnosis of exclusion in the emergency department to diagnose that rather than a myocardial infarction, right? Right. Okay, moving on. Time for a bio break. We will come back. We will do Cardiology 3. Thank you, gentlemen, again for your attention.